The purpose of this talk is to review the common indications for endovascular stent repair of the aorta, to review important anatomic aspects of the diseased aorta on pre-procedure imaging, and to describe some common and uncommon complications of endovascular repair on serial imaging surveillance. The goal of endovascular thoracic aortic aneurysm repair is to exclude the blood flow within the aortic sac while maintaining blood flow distally. You want to decrease the pressure transmitted to the native aneurysm wall, which will prevent rupture of the thoracic aneurysms. There's several advantages to endovascular stent placement versus surgical treatment. The advantages are it's less invasive, it's less painful, there's been proven less short-term morbidity and mortality, and it's also less limited by comorbidities. You can place endovascular stents in patients that are too sick to have open surgical repair, and they also have shorter hospital stays than open surgical repair. There are some limitations to endovascular stent treatment. It requires suitable anatomy. It has to be the descending thoracic aorta, the arch. You can't stent the ascending thoracic aorta. The overall costs for endovascular stent repair are higher than with open surgery, and there's limited long-term outcome data. There was a recent observational study of a large number of Medicare patients that showed that the proven early survival benefit of endovascular repair disappeared at 2 years, and that endovascular repair actually had worse 4-year survival when you compared it with open repair. They tried to adjust for comorbidities because the endovascular repaired patients were in generally sicker patients, which is difficult to do in Medicare registries, but even the best attempt to adjust for the comorbidities, open surgical repair still had better 5-year survival. So the long-term outcome of endovascular stent repair is not really proven. Lifelong follow-up is required, generally annual surveillance of the endovascular stents, and they are placed with iodine, and the surveillance imaging can cause contrast-induced nephropathy. There's several indications for endovascular stent repair, and they continue to expand. Common indications that we see are aortic aneurysms, both atherosclerotic and mycotic, penetrating ulcers, post-traumatic aortic ruptures, descending thoracic aortic dissections, aortoesophageal and aortobronchial fistulas, as well as it's a second-line therapy for aortic coarctation. Preoperative assessment with CTA, you want to describe any branch vessel involvement with the aneurysms, any angulation of the aorta, and the diameter and length of the aneurysm sac. The aneurysm neck should ideally be greater than 15 millimeters above the celiac and at least 5 millimeters distal to the origin of the left subclavian artery. If the aneurysm or dissection extends to the origin of the left subclavian artery, that doesn't necessarily preclude endovascular stent placements. Frequently, the vascular surgeons will go in and debranch the subclavian and do a subclavian to carotid bypass if they need to stent across it, or if they need to extend a stent across it to repair an endo leak. You want to also evaluate for the present and extensive aortic wall calcification and mural thrombus. You don't want to seat the stent in an area of mural thrombus because that increases the risk of endo leaks. And there should ideally be 40 to 42 millimeters or less of the diameter of the proximal and distal aortic necks. If you're evaluating the abdomen on these preoperative assessments with CTA, and they do chest, abdomen, and pelvis because they go in through the femorals, if you happen to be looking at the abdominal portion, the femoral and iliac artery should be 9 millimeters or larger and without significant tortuosity. The typical stent delivery system is 25 French, which is a little over 8 millimeters in diameter. And generally, we qualitatively assess the tortuosity of the aorta. It's crooked, kind of crooked, really crooked. There was a recent study which they actually quantified the tortuosity using a tortuosity index based on a median centerline curvature, and found that you can quantify it and it correlates well with the development of endo leaks. In general, you want to follow these follow them with serial CTA surveillance after endostent repair to confirm and document the appropriate placement of the stent graft. You'll follow up after stent placement is done with CTAs at 1, sometimes 3 months, but generally 6, 12 months, and then annually thereafter. And when you're following these up, you want to assess the effectiveness of the stent graft and excluding the aneurysm, detecting endo leaks or flow in the excluded aneurysm sac. You'll follow the long-term fate and the size of the sac and ensure its stability. You want to look for evidence of stent graft failure, either structural or functional, and you want to characterize endo leaks. There are some immediate postoperative complications when you put these large the catheters in the aorta and the stents. They can cause aortic dissections and perforations. You can also have vascular access trauma outside of the aorta. The iliac artery can be traumatized from the endovascular stent placement. And there's thoracic postoperative complications. If you do cover over the origin of the left subclavian artery, you can develop upper limb ischemia. And some of these patients also develop paraplegia. The etiology is not certain, but probably has to do with occlusion of the intercostal arteries, the artery of Adamkiewicz, and the anterior spinal artery. It is worth noting that the rate of paraplegia developed after endovascular stent repair is the same or better than that with open repair. Other complications include stroke, myocardial infarctions, renal failure, pneumonia, and chronic ischemia. Late complications, which we frequently are the first ones to detect on serial follow-up, include endoleak, aneurysm sac expansion, stent migration, kinking, fracture, or collapse, pseudoaneurysms, perforations, or other thrombus. We'll spend a little bit of time talking about endoleaks, which by definition is persistent blood flow within the aneurysmal sac outside the lumen of the endoprosthesis. The endoleaks are the most common complication of stent placement, and it's estimated to be up to 15% in various studies. Here's kind of a busy graph detailing all the different types of endoleaks. So the type 1, or the attachment site leaks, are the most common in the thoracic aorta. They're subdivided into type 1A, endoleak at the proximal attachment site, or type 1B, an endoleak at the distal attachment site. There's a type 1C, which involves an aortoiliac stent graft, which occurs below the diaphragm, so not really important. Type 1A endoleaks are generally repaired immediately. Frequently, they'll see them in the operating room with angiography, and they'll go ahead and extend or put another stent graft extension beyond it to repair the endoleak. If you do see them on follow-up surveillance, and generally they'll repair them as soon as they're made aware of them. Type 2 endoleaks are retrograde flow through branch vessels. These are most common in the abdominal aorta, where you can get them from the internal mammary or lumbar arteries. You can see type 2 endoleaks in the thoracic aorta. If you have covered over the origin of the left subclavian artery, you can get retrograde flow through that, or you can get retrograde flow through the intercostal arteries. And then the type 3 leaks are the structural graft failures, either the strut fractures or the fabric tears, or you have a breakdown where you have two overlapping stents. Here's an example of a type 1 endoleak. This was a patient who had a descending thoracic aortic stent graft. Here you can see a portion of the graft. This is contrast outside of the graft within the native aneurysm sac, and it's coming up from the bottom, so this would be a type 1B endoleak. And here you can see the 3D volume rendered reconstruction showing the contrast coming up from the bottom, so a type 1 or 1B endoleak, and they repair these usually with stent graft extensions if they can. Here's another patient, a 45-year-old who had an anomalous right subclavian artery with a Commerell's diverticulum and an aortic dissection. Dissection was a type A, and so they were treated with an elephant trunk or a modified elephant trunk procedure with stent completion. And you can see on this sagittal reconstruction, here's the endovascular stent graft. Here's all the contrast in the native, or in the false lumen and the aneurysmal dissection of the part that's supposed to be excluded. And it was felt to be coming from the proximal attachment side of the stent and extending downwards. When you do stent graft therapy for dissections, you always get some flow, because they never extend them all the way down to completely occlude the dissection. A lot of times they'll need some flow in the false lumen to supply visceral branches that may be coming off the false lumen. So you'll frequently have flow coming up beyond the distal attachment of the stent graft into the native aneurysmal dissection sac, and that's generally okay. You just want to watch the aneurysm sac size and make sure it's stabilized or decreased and doesn't continue to increase. On the axial images, you can see that extraluminal contrast from what we thought was a type 1A endoleak. We thought most of this was coming from top down. And then they also have an intercostal artery with a little blush of contrast, which we thought was a type 2 endoleak, probably not relevant in this patient. The patient did have, was taken to the OR. The type 1 endoleak was confirmed. And then they did a arch debranching and a stent graft extension to treat the endoleak. And here's some 3D volume rendered reconstruction showing the extension of the stent graft, and the patient did well. Here's an example of a type 3 endoleak. These are two non-contrast CTs performed approximately 1 year apart. The examination over on the right was the one taken a year later than the one on the left. And for people with renal failure, frequently we'll just do non-contrast CT examinations and just monitor the overall size of the aneurysm sac. If the native aneurysm stabilizes or continues to decrease, then in theory there shouldn't be increased pressure on the aortic wall, and they shouldn't be as much of a risk of rupture. So as long as the sac size has stabilized or decreased, we continue to follow them without intravenous contrast. This patient, though, as you can see, the native aneurysm sac has obviously increased over that year interval, which is presumptive of an endoleak. Without contrast, you can't really characterize the type of endoleak and determine the best therapy. So this patient was admitted to the hospital and kind of tuned up for intravenous contrast examination, and that's what we see here. And with the contrast enhanced images, you can see a very large endoleak. There's a large volume of contrast adjacent to the stent graft in the proximal descending thoracic aorta, and tracking it down, there was some irregularity of the struts kind of in that area. The endoleak wasn't seen communicating with either the proximal or distal attachments of the graft, and was not what didn't seem to be coming from a intercostal artery, so it was presumed to be a type 3 endoleak. We did 3D reconstructions to look for any evidence of strut fractures or, mechanical disruption of the stent, and we didn't really see any. And you can do the fly-through views, which are kind of neat, but probably not that helpful. We still didn't see any. And we turned it a pretty shade of blue and still didn't see any strut fractures. But it's still a type 3. The fabric was torn, and so he was taken back to the OR, and they put in another stent to cover up the fabric tear, and did reasonably well. That seems to be a recurrent theme for the stent graft problems. They take them back to the OR and put in more stents. Here was an example of an older exam with a patient that actually had a metallic stent fracture, and you can see on the 3D volume rendered reconstruction there's disruption of all the posterior struts, and you can see kind of on the older fly-through view the struts are disrupted, and this was also repaired. 3D reconstructions are very good for visualizing strut fractures. Chest radiographs can also show them, and we'll show an example later. This was another patient with a type 3 endoleak, and when we're passing through, you can see several of the struts have kind of deformed and are now bowing into the middle of the lumen of the aorta. And you can do 3D showing the struts bowing in the middle there. This was a 50-year-old patient, came into the emergency department with chest pain. She had a prior mycotic aneurysm repair. The radiograph on the top here was taken immediately or before discharge from the hospital, and you can see the position of the stent graft. This was the portable exam that was taken when the patient came into the ED. And I remember reading it, commenting specifically that the appearance of the stent graft was unchanged, but it's not really unchanged. If you look, and it's going to be hard for me to line this up, there's a tiny line right there, a tiny linear density that really wasn't there. Now, where at the distal arch, proximal descending, you're kind of looking down the barrel of the stent, but there's a new line here which doesn't conform to what you would expect to be looking down kind of the barrel of the stent. And I suspect if one of the expert film panelists had been covering our ER that day, they would have known that it was the overlapping stents with collapse of one of the internal stents, but I called it normal, or called the stent unchanged anyways. Here was fortunately though, the patient was in the ER, so they did get a PTE study, and we have a nice example of a stent collapse. This patient had overlapping stents, and one of the overlapping stents had collapsed, and you can see it very well in the middle of the aortic lumen, kind of like a seagull configuration, and on the sagittal reconstruction, you can see the stent has collapsed. These are emergencies because they can progress to complete aortic thrombosis pretty quickly. So this patient was taken back to the OR, and more stents were put in. Here's kind of a pseudo chest X-ray showing the collapsed stent. There's that little line I didn't see. A little bit about bird beaking. This can be confused with a type 1 or type 1A endoleak, but is not a true endoleak. The endovascular stents will have metallic rings along the proximal and distal aspects, and those rings are markers for the parts of the stent that are actually covered. Beyond those rings, struts will stick out, but those struts are not covered, and so those little struts can go over the origins of vessels and not really cause a problem. But where that ring starts and beyond is where the stent is covered. When they put these stents in the thoracic aorta, it's curved and the stents want to straighten out a little bit. So along that inferior curve of the arch, you'll frequently have the bottom lip of the stent pull up and you'll get a little bit of contrast to come in there. It's not a true endo leak. The contrast is not in an excluded portion of the native aneurysm, but it may predispose people to developing endo leaks, and it's probably one of the reasons why the type 1 endo leaks are the most common in the thoracic aorta. These are typically managed conservatively. If you see this on the 1-month follow-up, you may want to get a 3-month follow-up instead of waiting 6 months. They're just surveilled. They're not treated in and of themselves as an endo leak. Briefly on the elephant trunk procedure, we saw a picture of that a little while earlier. This is a 2-stage operation for more diffuse or complex aortic diseases. People that have both ascending and descending disease or arch and descending thoracic aortic disease may undergo an elephant trunk procedure. The first stage is a repair of the ascending thoracic aorta, an aortic interposition graft, and an arch reconstruction. With the graft that they put in, they leave the distal portion of the graft kind of floating freely in the proximal descending thoracic aorta. The portion of the graft after the stage 1 repair kind of hangs out and resembles a little bit of like an elephant trunk. The second stage, they repair the descending thoracic aorta. In the classic elephant trunk procedure, this was done via left thoracotomy and a descending thoracic aortic interposition graft. Currently, more commonly now, they're doing modified or hybrid elephant trunk procedures where they use an endovascular stent to complete the elephant trunk to repair the descending thoracic aorta. Here's some images from a 45-year-old patient with Marfan syndrome who had a thoracoabdominal dissection and aneurysm. This is after the stage 1 of the elephant trunk, and you can see on the first picture the portions of the graft that are hanging out in the proximal descending thoracic aorta. These can be confused for dissections, but it's intentional. And so you don't want to make that mistake. Here on the sagittal oblique reformatch, you can see it looks very tubular like a graft, and then you can see the aneurysm and the dissection. And on the last image, you can see the stent graft completion of the elephant trunk procedure. This patient unfortunately had a type 1 endo leak, so they had to go in and put more stent grafts to cover that leak, and then did reasonably well. Surveillance imaging radiography is primarily used to detect kinks and fractures in the stent grafts. Traditionally is considered superior to CT, but 3D reconstructions of the grafts may eventually obviate the need for radiography. We're currently still getting multiple oblique images to evaluate these stents radiographically. Surveillance imaging, CTA, is the most widely used. MR works very well for certain types of stents, the nitinol stents, but you can't really use it for the stainless steel stents. And I think even with the nitinol stents, thoracic or the vascular surgeons are more comfortable with CTA, so we tend to mainly follow all of our patients with CTA. You can do multi-phase imaging, which is recommended to detect delayed endo leaks, and that gives you a little higher radiation dose, but you can pick up more endo leaks that way. And then there's various post-processing imaging techniques you can use, and depending upon the renal function and clinical status of some patients, we now just follow them with non-contrast CT and see if the native aneurysm sac expands, and if the native aneurysm sac expands, then we'll evaluate them further. New dual energy CT techniques may allow substantial reductions in radiation and contrast dose. You can replace the unenhanced acquisition with a virtual unenhanced series, and you can also use the monochromatic beam reconstructions, the lower KV monochromatic beams, which allow you to give a substantially reduced contrast dose. This is still kind of experimental, and so there's not a whole lot of data out yet on it. Here was an exam that we did, and on the top you can see the virtual unenhanced series. This was given with contrast, but the iodine was subtracted, and then you can see the iodine map showing good opacification of the stent graft and the descending thoracic aorta. And here's just some examples of the dual energy using the different monochromatic beams. So the top corner has the 50 keV beam, which is closest to the K edge of iodine, and you see the descending thoracic aorta is very brightly enhancing. The other two images were taken with a 140 keV monochromatic beam. This window and level is the same as this window and level, and you can see the contrast in the aorta is very hard to detect. The window and level was adjusted just to kind of prove that it was an enhanced study, but the enhancement is much less conspicuous than on the exam in the top right. There's some issues with the virtual non-contrast imaging doing the trying to subtract out only the iodine without subtracting out the calcium, the material decomposition, so it's not perfect, but it may play a role in the future. Surveillance imaging, MRI, can be used for certain types of stents, and ultrasound may have some role in abdominal aortic cases, but is not really used in the thorax.